Welcome back to Plastic Surgery Untold. Today we have a very special guest, and we're going to talk about a topic that I don't think we've ever had on our podcast before: labiaplasty, vaginal rejuvenation. And so, super excited to have Dr. Mark Epstein all the way from New York. So, excited for you to take time out of your busy time in the big city to join us on our podcast.
Well, thank you so much for having me. I greatly appreciate the opportunity.
So I know labiaplasty is a big part of your practice. You're also world renowned for your breast surgery. So maybe we'll have you on for another episode to do that. But let's talk about labiaplasties for now. Maybe you can give us a little recap of what that actually means, because I think people use that term a little bit fast and loose, but in plastic surgery it tends to be a little bit more specific.
Yeah, the labiaplasty, what most women come in with is a complaint that they have too much labia minora. That's the inner lips. The outer lips is the labia majora, and that's a whole separate issue. Fixing that is also a labiaplasty, but the vast majority involve the inner lips and also around the clitoral area. It's called the clitoral hood. The women come in, they complain that they have extra tissue. When they stand up, it hangs down past the borders of the larger lips, that it interferes during sex. They're self conscious. Sometimes there's hygiene issues. They can't enjoy sex. A lot of them can't climax because they're so preoccupied about their anatomy that they can't concentrate on the moment. And they're really distraught.
And talk to me a little bit, because most of the patients that I've had in our practice and don't nearly have the experience you do, but people have thought about this for a long time, because it has been something that has caused them issues for years. It's typically not something that people just come in off the cuff.
Now, this has been going on for a long time. I've been in practice about 30 years. And it was interesting. The very first time I saw a patient for this, she told me that she didn't realize she had a problem until she was playing softball and she saw the pictures, and she was very surprised at how she looked. Then she filled me in that she was playing nude softball. So I
Yeah.
understood the situation.
Oh, yeah.
And I'm going back about, oh God, almost 30 years. And on the day of the surgery, she came in with a book. I think you can still get it on Amazon. It's called Femalia. And it's 32 full color pictures of women's vulvas to show women that there is no normal. And this
Mm,
is true. There is a lot
mm.
of variety. But she came in with the book and she had some post-its on a couple pages. And she said, these are the ones I like the best.
Yeah. That
So it was my first labiaplasty. There was really nothing written on it. So during surgery, the nurse held the book open to the one with the post-it, and I did my best to try and simulate the results to look like the picture. And she was very happy with it. But when I look back on that surgery and that results, it was really very primitive, and the results then are nowhere near what we can give aesthetically now.
Yeah,
Right.
that brief story reminds me of, and you may be familiar with this, the sort of the art project called the Great Wall of Vulva.
Mhm.
Yeah. It's interesting, because we have a lot of patients that come in and say, "I just want to look normal," but there is none, and I think that's
Right.
a good education point. Jumping into the procedure itself that you already alluded to, because there's a couple different techniques to do labiaplasty, and maybe we'll start with you, Mark, but then go around the room here and see kind of everybody's techniques, because almost a hot topic at some of the national meetings is there's a few different ways to get to a good spot.
This is true. The classic procedure is called the lateral trim, and it's technically very simple to do. The gynecologists generally do this, and I think most plastic surgeons are still doing it. It's a procedure where you're just pulling the skin out towards in the direction of the knees, and from top to bottom, you just snip off the extra skin. Aesthetically, the results are not the best. It does not address the clitoral hood. And there's not only a horizontal excess of tissue, which is when you pull the tissue out towards the thighs, but there's a vertical excess from top to bottom, from front to back.
Mhm.
And if you don't tighten them up in vertically, what happens is, even though you shorten them horizontally, the tissue is still very redundant and lax, and sometimes will even still protrude past the labia majora borders. It tends to look very senescent, like an older woman's vulva. And as I said, it doesn't address the clitoral hood. So if there's a lot of clitoral hood excess, then it can even look like the woman has a small penis, which definitely doesn't go over very well, at least not with my patients. The last thing is, because you're cutting away the natural labial edge of the tissue and you're replacing it with scar, healing is unpredictable. And at best, you can get an okay result, but sometimes you get a scalloping, and that's unpredictable. It's happened to me too. And it really looks very funny. So I've abandoned that procedure
What
completely.
does that what does that do to sensation? Because that's another area that's super important in thinking about this procedure.
Yeah, I get asked that question a lot. And one patient recently even told me that her mother, who is a medical malpractice plaintiff's attorney, told her not to have the surgery because you'll lose sensation. That's really a myth, because the nerves come down from deep and move and come up to the surface. So um, you're by trimming the labia minora, you're not going to denervate it. You're not going to lose sensation by trimming and adjusting the labia majora. Same thing. You're not going to lose sensation. And with the clitoral hood, again, you're not going to lose sensation. The only time you can risk losing sensation that I'm aware about is if you're trying to shorten and elevate the clitoris itself, which is a procedure that in my practice, I've really not had a patient who needed it. And when you're doing that, that's tiger country. You're down by the clitoral nerves, and I'm not sure that's really worth the benefit. But if you do a clitoral hood elevation and a clitoral hood resection, what you'll do is you'll tighten the clitoral hood and elevate it, exposing the clitoris just a smidge so that you improve sensation a lot. I tell patients it's kind of like analogous to a condom being made out of thin lambskin versus out of shoe leather. If the condom is made out of shoe leather, no one's going to feel anything. But if it's made out of something thin, then you'll transmit sensation. So you want the clitoral hood. You want to get rid of the excess clitoral hood so that the tissue is spread very tight across the clitoris and it's thin, so that there is good transmission of pressure down to the clitoris.
Yeah. So if I may, if you've abandoned or perhaps never even really used the technique that you just described, what is the technique that you have found to be most effective?
That's a great question. I have done quite a few lateral trims, and then aesthetically, I just wasn't happy. And that's why I moved to the central wedge, which is a wonderful procedure. I use it about 70–80% of the time. It addresses the horizontal and the vertical excess beautifully. And you can actually come up the side all the way to the top to the clitoral hood and incorporate the clitoral hood resection at the same time as you do the wedge resection. And then the clitoral hood elevation is just a tiny little upside down V resection that I do at the very end of the procedure. So that's a great procedure. It's technically easy to do. The big criticism on that procedure is people worry about fistulas, openings, almost it looks like a piercing in the labia minora. I've actually only had one or two in the last 10 years doing that procedure. And the reason is because I do it as a 3-layer closure. That inner layer of closure is absolutely critical. And when you tumesce the tissues with local anesthesia and they're all spongy and thick, it makes it very easy to see that subcutaneous layer, because it's like a sandwich of subcutaneous tissue with mucosa on either side. So if you can get that subcutaneous tissue nice and thick with the tumescent tissue and put a row of interrupted sutures in that layer, you will all but eliminate the risk of a fistula, and then you end up with a beautiful result. I have on my website comparisons that show a patient of the same age with a lateral trim and with a central wedge, and the results, the difference is just huge.
If I may, to try to simplify this for our savvy yet often not medical audience, in that, are you removing sort of a pizza shaped, a slice of pizza shaped wedge from the inner aspect of the excess, and then have a superiorly based uh, flap of tissue, if you will, that you then bring down? Is that what I'm understanding?
That's exactly what it is. It's like a sidewards pizza wedge. So it's going like this in that direction. That's when you look from the front, but from the back, it's actually more of a hockey stick shape. So it's two different shapes. And when you put everything together, it just fits beautifully.
And the thing that I love about that you've talked about is that the only thing on the actual edge that's going to be kind of out or visible, from a standing or position is one tiny little line and then something that kind of runs down in the fold. So you don't have the scar along that entire outer edge. And that's why like you, I've adopted that and been super, super happy with, especially if you anatomically put those edges together, the risk of wound healing has gone down dramatically.
Yeah, if I'm understanding the two of you correctly, that's what I have migrated to as well. And I like the fact that you don't have a scar on the leading edge of the labia.
Exactly. Because if you look at the leading edge of the labia, it tapers to a very thin edge, almost like a knife. And when you cut across it, you have a thick blunted edge and it just doesn't look natural. I had an 18-year-old that I did a revision on. She had a gynecologist do a lateral trim, and fortunately they under resected her, so I had enough tissue to work with to convert her to a central wedge, and she looked good as new when I was done. The beautiful thing with the central wedge is if you put your incisions in the right place, it is nearly impossible to see the scars. I mean, I know where I put the scars and I have trouble seeing. So we have, with my patients, they all know about the gynecologist challenge. And the gynecologist challenge is I tell every patient, if you go to a gynecologist and you don't tell them that you had a labiaplasty and they say, hey, did you have an alteration down here? I want a phone call, and I don't care if it's 3 a.m. And they all have my cell, and I've yet to get my first phone call.
Kind of interesting if they're seeing the gynecologist at 3 a.m, but that's a podcast for another day. But
Yeah.
But
That's competitive there in New York.
but can we maybe hit up a couple questions here? And one, before we get to that, Dr. Arredondo, you do a couple other little techniques, and then I want to touch a little fat grafting and then recovery stuff as well.
Sure.
You do something a little different.
That's right. So I'm a little bit newer out of training, but most of the surgeons I practiced with did a lateral trim, and I really wasn't super thrilled with the results either for reasons that you've already explained. But after doing a pretty extensive dive on different techniques that are available, I settled on something called the flask technique. And so what that is it doesn't involve a full thickness resection of any of the tissue, but it involves basically leaving two wedges of tissue on the top and the bottom, and you just take off the superficial layer, the skin layer. And so you can control the height and the length. So you get both the lateral and the vertical excess like you were talking about, and you sort of lock those together like this. And it leaves that thin leading edge of tissue, which I thought was super important. And also it has it has almost no rate of fistula because you're still leaving tissue there. And
That's a great procedure. And as I said, I do about 70% central wedge. The other 30 is the custom flask. And it's interesting. Federico Gonzalez described that around, I think, 2017 or 16, something like that, in Annals of Plastic Surgery.
2015. I have the article on my computer.
And it's funny because at the time at the time his article came out, I had a young girl. She was 15 years old. She had a huge labia. Now, instead of being like a tongue of tissue going to the side, it was a very broad wing of tissue. And to do a wedge on her, and she was a virgin, would have necessitated extending into the vaginal canal, and that would have resulted in vaginal stenosis or narrowing and making intercourse nearly impossible. So doing my research, it just happened that month. Federico published the article. So I called him and I asked him about the procedure, and he kind of walked me through it because this was a really extreme case, probably the most extreme case I've ever had. And the results were absolutely amazing. The thing to understand when you do a custom flask is it does not address the clitoral hood. So you have to address the clitoral hood separately, which is very doable. It's not hard, but it's something you have to recognize because you can't incorporate the design. But you bring up a very good point. It allows you to address the vertical and the horizontal dimensions perfectly. So it's a great procedure, and it is suitable for 100% of cases if that's your choice, whereas a central wedge, probably 70 or 80%. I like doing both because I find the central wedge a little bit easier to do in cases that are straightforward. But if you like doing a custom flask as your go-to, you can do it 100% of the time and get killer results.
Sometimes we like to make things complicated.
The thing I love about both those techniques is you're preserving that natural aesthetic anatomy of the labia, because some of the, just horizontal excision stuff you can lose, and there's actually a transformation of color and look and so forth, and especially if it's a much bigger resection, as you're alluding to on some of your patients, Dr. Epstein. And so I love that you can take a significant amount of tissue but still keep that nice natural anatomy. Like you said, people, their little secret in terms of whether they've had something done or not.
Right.
Exactly.
I'm gonna briefly pretend like we had an audience member calling in and ask a question on their behalf.
Oh, okay.
And we may all have different answers to this, but is this something that patients need to go to sleep for, or can it be done under local? How about our guest?
When I started doing labiaplasty, we put everyone to sleep. Now we put almost no one to sleep. I give the patients a choice, but everyone seems to want to do it awake. And the way we do it is I use a special cocktail of Exparel, which is a long-acting local anesthetic, and Marcaine, which is a long-acting anesthetic. But Marcaine lasts about 8 hours, and Exparel is Marcaine in a little liposome delivery system. So it's released gradually over a period of 2 to 3 days. So the combination of the two gives me immediate analgesia and long-term. So the patients feel nothing, absolutely zero. They have a pain score of 0 for 24 to 48 hours. And by the time that the medication is wearing off, they go to Tylenol, Motrin, and gabapentin. I never have to prescribe narcotics to the patients. So it's a really, really nice way of doing it. All they feel is 2 tiny little pinpricks. Actually, now I use an insulin syringe with the cocktail, and I put a little bit in the posterior part of each labia minora, just a little bleb. And then as you push the fluid ahead of that, they don't feel it. So they actually feel nothing. So they just, listen to music. They have Pronox available. So what we do is we get them good and relaxed on the Pronox. I have them take about 8 or so really deep breaths. They don't even feel the 2 pinpricks. And after that, they feel nothing. So it's a great experience. And 15 minutes or so after surgery, they're on their way home.
Dr. Weinfeld, what's your choice, method of choice?
I've done it mostly asleep, although I've done a couple awake. And the reason is that I have sort of a small side practice of adolescent patients. And so that's sort of a different population. And so for that reason, they just prefer to go to sleep. But I love this idea of the Exparel. I had not considered that. Very brief technical point. My understanding is, I could be wrong, that you're not supposed to mix something with epinephrine with your Exparel. Maybe that's not true, but if it is, do you care?
Lidocaine. You can't mix lidocaine with Exparel because it'll cause the Marcaine to come out of the liposomes. But
Gotcha.
So what we do is we actually use epinephrine right out of the vial, the 1 to 1,000. So I take 0.3 cc's of that, and we take 10 cc's of Marcaine, 0.5%, and 20 cc's of Exparel. So it's 30.3 cc's.
Okay.
And then
clearly my misunderstanding.
Yeah, and then we have some left over, usually half or a third of it, and then we put that in at the end for a little bit extra relief, and they do great.
Dr. Arredondo, how did?
I think I'm exactly 50-50. I've done half of them awake, half of them asleep. Usually the people that are going to the OR are doing so just because they're having another procedure done, and they say, you know what, while I'm there, why don't we go ahead and do this as well? And it's easy to do. I still treat them, though. I don't use Exparel, but I love the idea because I'm a huge fan of Exparel. But I still do all the same numbing, local anesthetic that we would do otherwise if they were awake, because I think that it not only helps with bleeding control for the epinephrine, but also the long-term pain relief. And I use traditionally a mix of lidocaine and Marcaine, but I think I might switch to Exparel. I love that idea.
How about recovery for you guys? What do you guys tell people in terms of recovery, getting back into exercise, intercourse, back to work?
Okay, I tell them nothing goes inside, living or dead. No body parts, nothing official for 6 weeks. They cannot go on a bicycle. They cannot do spin. They can't motorcycle, horseback, ride camels. Nothing that could put pressure on there for the 6 weeks. I see them a couple days later, make sure everything's good. I see them at 3 weeks. Usually, I like using 4 sutures. They hold well, but they're a little stiff. Sometimes they cause some etching at that point, and then not itching. And then I see them at 6 weeks. If everything is healing well at 6 weeks, and it always is, then I release them for date night. I do advise them to get a water-soluble lubricant like Astroglide to use just the first few times, because things haven't been used for a while. They may be a little bit snugger, so it makes it a little bit more comfortable and less traumatic for the surgery. And then I see them at 12 weeks, at which point all the swelling is gone, which is amazing at 3 months that they look that good. And we do 2-dimensional and 3-dimensional photographs at the same time.
Dr. Weinfeld, anything different?
Yeah, exactly the same with regard to that 6 weeks. I'm not sure where I came up with that, but it seemed, an area that has a relatively significant blood flow, that things would heal on a faster pace. And so I just came up with 6 weeks.
Dr. Arredondo, anything different? I do 6 weeks as well.
I do 6. I use slightly different sutures, but same exact recovery protocol.
Team, just we're running close on time here. Maybe I'll go around the room. Do any of you have any 1 or 2 last tidbits you would leave for patients considering a labiaplasty? Maybe either considerations for before, after, or picking the right surgeon? Dr. Epstein, maybe kick us off.
I think looking at results and making sure that the surgeon has enough experience. There are a lot of surgeons who are keen on getting started with it, but experience and training varies. You want to see a variety of pictures, and you want to see results, and make sure that the results you see are what you want.
And if people go to your website, you actually have a really cool video on that, and maybe we'll find a way to link that on this podcast stuff, because you did a really cool job with that I've seen on your site. Dr. Weinfeld?
Yeah, I guess what I would say is that there are benefits in addition to appearance. You mentioned hygiene. Many women report having toilet paper kind of stick to the extra labial tissue. And then many women complain of being able to see the labia in bathing suits. And then there's the whole discomfort while riding a bike or spinning. And so there's a lot to look forward to, in addition to just having an appearance that you feel more confident about.
I think it's the number one in my practice, the number one impact on self confidence and self esteem. I used to think breast reduction did the most for my patients, but it pales. My plasty patients all use the same phrase, life changing. And it really is. When they come in, they talk about their sex, how much better it is. Sometimes the partners even have a better experience. It's just a great procedure. And I recommend for any woman who's having these issues to give it some thought, consideration, do your research, find a surgeon, and consider getting the procedure.
Yeah, and you mentioned the confidence and the emotional impact. We should remember the biggest sexual organ is the brain, right? And so if you're confident, your brain is going to be able to allow you to relax and to have a far better experience with sex.
Dr. Arredondo?
Yeah, I have. So I want to touch. I don't have anything technical to add to the expert here, but I've learned a lot. But I think the emotional impact is something that I've really underappreciated. I had a patient who was so self-conscious. She said that she's had this issue since she was a teenager, and just was literally in tears over this. And because she literally couldn't even sit on the toilet and pee normally, she just had spray from her urine flow. Did a labiaplasty. That night she went home and she peed for the first time with just a clear stream, didn't have any spray, didn't have any splatter. And she said she just cried because she was so happy. So it's a huge impact. It's under-discussed, and I know it's very personal. And so I'm just happy that we have the opportunity to help people in this way.
Dr. Epstein, we are out of time, but definitely want to have you on board again, because I think there's so many more things we can talk about this. Before we let you go, can you tell all of our listeners how they can find you if they're on the East Coast, or they just want to come to see an expert for their labiaplasty?
Well, I have a website, epsteinplasticsurgery.com. And on the website, there's a photo gallery that has photos. The photos show before and afters, both regular 2-dimensional photos, but we also have 3D moving synchronized video. So you can actually see before and after synchronized from all kinds of different positions. And you can get a much better idea topographically of what the surgery will do for you. And I have several dozen examples of cases on the website, so you can view it. There's also a section under the surgery area where there's a one page on the website that explains the procedure top to bottom in layman's terms, a lot of diagrams, gives you a great understanding. I use it when I meet with my patients, and information is king.
I like what you did there from top to bottom. So on that note, Plastic Surgery Untold, greatest podcast in the world. Thank you again for taking time on your day to join us. You can find us anywhere you find your favorite podcasts, iHeart, Spotify. You can actually see us on YouTube if you want to see our pretty faces. We'll see you guys. Bye.
All right.
Bye-bye.